So my presentation for you today is Community Health Center's impact on primary care and public health. So as we roll through today, I think as probably public health students, you probably are very acquainted with this statistic, and I think it's one of our driving forces in the Community Health Center movement. But really, what are we doing wrong when we spend $8,000 per person who lives in this country and we can still rank 37th in health outcomes? So value for the things that we are able to provide for the people in our country. The Prime Minister of Canada said beating the United States in healthcare is like beating a midget at basketball. And that's a sad fact when we pride ourselves at being the best in the things that we do. So the objectives of my presentation today are not to bore you to death, number one. Number two, give you a brief history of the movement that I've worked in for the last 7 years. Tell you about the unique features of it, the requirements to be a federally qualified health center, the benefits to patients in the community. I want to just give you a brief overview of what the Affordable Care Act how it's impacted healthcare, and then just a history of our organization and how we're making our mark today. So federally qualified health center is actually the grant itself, the federal government. It started in the Johnson administration. Johnson was a president. The Johnson administration, it was a public, it was really a social justice movement. There was some funding, and some actually Masters of Public Health students were asked if you were given some funding to go into communities and help people have better lives and get out of poverty, what would you do? And they said we would go in those communities and ask people what they needed. Brilliant. When they went and asked them what they needed to get out of poverty, by and large, most of them wanted access to health care, primary care. They wanted some place to call their doctor's office. At that point in time, you went to a clinic or you went to the emergency room, and if you were poor, you didn't have any chance to go to a doctor's office unless you bartered for it. So from that, the movement started, as we call it, the movement, migrant health care first and then primary health care. And then HHS created language within governmental regulations that say that this kind of contract with independent organizations will be funded in one way or another. So it protects us from some of the funding that we receive to provide these services. We are, the grant itself is the financial model, what we call that's the FQHC, or Federally Qualified Health Center. The Community Health Center model is that model of care that's integrated into the community. And the model is really meant to be patient-centered and always has been for 40 years. So we were patient-centered medical homes before that was cool. They are always meant to be in areas that are medically underserved and have provider shortages. And they're meant to provide high-quality, cost-effective health care to those in most need. So this is the 19 requirements to be a federally qualified health center. So you sign a contract with the government, and for that you get an amount of money to provide care in your community, and your half of the bargain are these 19 requirements. Daunting. Each one of them has a volume that's related to it, but they all start out with, the first thing you can see at the top is a needs assessment. You can't be a federally qualified health center unless you determine what the need in your community is. And of course, it's really based on the great equalizer of poverty. So we serve people at 200% of poverty and below, but our doors are open to everyone. But we target and focus care to those in poverty. We do a needs assessment. We always have to provide primary and preventative services. Enabling is a huge area, and that includes language services and navigating to appointments, as well as things like transportation. You have to employ the majority of your staff. You have to have accessible hours. You have to have some kind of coverage 24 hours a day. You have to be in a relationship with a hospital. You must have a sliding fee scale for people at 200% of poverty or below. 100% of poverty and 200% of poverty are the triggers in many communities to get Medicaid, but at 133% of poverty, you have to have other things that happen to get you any kind of Medicaid coverage. You have to have a quality improvement plan. You have to have a significant number of management positions that are required to have. Blah, 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 blah. 51% of the patient or of our board of directors are patients. I think that's something that you should really remember about our movement. That means that our board has authority. They govern what we do. I'm the only employee of the board of directors, but they create a vision. So when the vision's created by people who don't live in your neighborhood or people who are on the board of other big organizations, say hospital systems, and that's at a really high level. And our board of directors are always people who get services from the health centers, which means they know what people in their neighborhoods need, they know what need looks like, they know what health disparity looks like, and so they help to quickly be able to help us to have a vision that shifts when the needs in the community shift. That's one of the unique differences. And all of these together, we are required every 5 years to do the needs assessment and report out on how we're doing with each of these, and then annually we do an updated report to the federal government. So what? Why do you want one? Why would you want to do all that? It brings a higher Medicaid and Medicare rate to the organization that does it, which in turn helps the community. It also brings $650,000 to each of the organizations. That's federal dollars. It's targeted to communities that have higher levels of poverty. It gives access to 340B drug pricing, which is the same price that the Veterans Administration purchases medications for, and it allows us an opportunity to give that savings back to patients. It also allows us the opportunity to share that with our insured patients, and if there's a cost savings, we split that so it helps us to drive our bottom line. And if you, as you continue your education through public health, I think you'll see that one of the biggest erosions into the cost of healthcare dollars is pharmaceuticals, and this is the only country where pharmaceutical pricing is not controlled. So a Lipitor in this country can cost 11 to 30 times what one in another country that controls those costs. So we pay for all the research and development that occurs in medications. This allows the people in need to get access to a consistent list of medicines at a very affordable price. It allows for malpractice coverage to this community, so that means that services that other organizations have trouble continuing to pay for, like OBGYN services, where there is a high malpractice, the federal government covers us for that. It allows us to get into relationships because of something called the safe harbor, where as long as we are taking the best interest of the patient in first, we can have relationships with organizations that other primary care organizations can't. So we can own our own X-ray department and refer to ourselves if it's the best cost savings. And it allows you to get other federal dollars. So it's an avenue for more federal money to come into the community. This is direct operational dollars, so directly to the care of people in the community. So what's other benefits? So patients who go to federally qualified health centers are hospitalized 11% less than a general Medicaid patient. They have fewer ER visits, they have better infant mortality rates, and they have a higher patient satisfaction rate than other primary care styles. This is a slide I borrowed from the Community Health Foundation, which is now called the Health Foundation for Western and Central New York. They're the biggest not-for-profit foundation granting money to healthcare in Western New York. And they did a study on the quality of care of different kinds of primary care and came to find that the lowest cost growth associated with health centers on a national average. So if any other type of primary care expands, it's more costly. We show a cost savings in managing chronic disease patients. So patients who have chronic diseases are managed more effectively and more cost effectively. So this slide shows that when people who have a regular source of care. So the Affordable Care Act, or lovingly or unlovingly called Obamacare, what did that do for primary care in things that remained within it? There was a lot of grant money for transforming care, which is important. I think it's important for us to recognize that if you spend $8,000 per person and you're still able to come out 37th, it's not all about people stealing. There has to be something wrong with the model itself that should be reconsidered. And that's one of the things that this did. Community health needs assessments, putting a real focus on not just our organization every 5 years hires someone to do a needs assessment. Every other organization that does this does the same thing. Frequently, those needs assessments all live in silos. This is requiring agencies regionally to get together and talk about what these needs assessments all show and where we can get some traction on specific health needs in a community. It preserves Medicaid preventative services and adds new ones. So Medicaid and Medicare were really designed around paying doctors to take care of people once they got sick and not letting them care for prevention. And this opens the door for us to see primary care in its true way that it's meant to be seen, and probably one of the ways that all the other countries that are ahead of us keep costs down by focusing more on preventions. Affordable Care Act did help the community health center movement. We locally got 5 new access points for federally qualified health center. We got infrastructure dollars. We got some money to give people jobs during the beginning of the recession. And those are because of the belief that this is a good model and the evidence that shows it. And then emphasis on national prevention and health promotion and public health. The CMS Innovation Grant, I think, is something that's gotten a lot of people looking at it. That's really looking at different ways to provide primary care. Patient-centered medical home, right now, you get an extra, if you see Medicaid patients in New York State, you get $6 per patient per month. If you get to patient-centered medical home level 3. So that is a bump up that came through the Affordable Care Act to help people to say, well, there's these strategies that make a patient want to come to you. It makes their health outcome better, and it makes it cheaper. And if we throw a carrot out there, maybe more people will go and do this. That's the funding for that came through this. More dollars into National Health Service Corps, and we are a HPSA, or a health provider service area. We are always designated one as a federally qualified health center. But any of you that are going to be direct caregivers should look into National Health Service Corps. There is opportunities for scholars programs as well as loan reimbursement programs after you complete that enhance the money that's available for that. And this teaching health center concept. So instead of having residency training programs only in universities and hospitals, to have them at health centers. So what's our story as a federally qualified health center? Neighborhood Health Center started in 1987. So we are in a converted school building that was built in 1938 and closed in the early 80s. It was granted from the school district to the city, and a community center opened. And the community centers had federally funded Head Start and some after-school programs. But they really recognized that many of the children came in unable to participate in Head Start because they didn't have a doc and their shots weren't up to date. And moms didn't have care. And so they went around to many different organizations and said, will you provide health care? And the Department of Health came in and did shots, but they realized the kids didn't get the form filled out, they weren't connected to care. And so they finally wrote the grant for the federally qualified health center. This was Concerned Citizens. And that's how most federally qualified health centers have started. They're small organizations that see a need and they ask for help and don't get it, so they say, well, let's do this ourselves. So our story is no different. And in 1987, that school, the auditorium got converted into 14 exam rooms and a place to check in, and we opened, seeing our first patient in August of 1987. What's our mission? Community health center missions are always the same. They always have to have in them a statement about regardless of the ability to pay. So that's our first section. We provide healthcare, wellness, and related services regardless of the ability to pay. In the center section, we define ourselves as an organization that wants to move the needle on healthcare and wants to be known for saying we will do everything to eliminate health disparities by achieving health equity. So some of the things that we do to report to the federal government on race, ethnicity, language, homelessness status are really to help us to assure that we are caring for all people, no matter what their background is, that their health outcome will be the same. And the final part of our mission is that really we honor the relationship with the people, and they volunteer for us because the people who do that are the vehicle to us achieving this, and as well as our partners in the community. So as you engage with more not-for-profits, understanding what their mission statement is important, because not-for-profits are a community trust. They're a public trust. And so knowing that they do something important and that they don't pay any taxes, and why? So does this feel like a good enough reason to not pay taxes if we carry that stuff out? Yeah. So how many people do we serve? So this is our history. We have, in 2007, we were, just about 9,000 patients. We had a big shift in how many babies we delivered and the doctors we had to do that, and that helped us to redesign and rethink about our role in this community. And in 2010, we wrote a strategic plan that said, we give a pretty darn good model of care here, and we know that we're cost effective. So we made a vision statement to say that in 5 years we will double the number of people we take care of. And we made some strategies to do that. Increase the number of people we'd see at the 2 existing sites, look for a 3rd site, really drill into the need in the community. Why were people from certain zip codes coming to the 2 existing offices? And we researched that, and we asked questions, and we did community surveys. And we come to find out that really there wasn't enough access to primary care in the Lower West Side. And so we opened a 3rd site on the Lower West Side in the November of 2011. When you see that number going up there, from 2009. In 2009, we actually were financially in trouble. We had trouble keeping our doors open, and that was because of the loss of OBGYN. And we really did have to say to ourselves, what are we here in this community for, and do enough people know about us? And we started something. We received a grant in that year from the New York State Health Foundation to bring behavioral health into our office, have on-site counselors, with a thesis statement that if patients felt like there was less stigma in getting a counseling visit, they'd go. And if that counselor was near their primary care doctor, they'd be more likely to go. And in a 6-month period of time, the schedules were full and double booked, and people were coming with a higher rate than they did in the community. In that grant, we also wrote for a community health worker, and we wrote to have outreach meetings where our employees volunteered to come to a meeting for a half hour a month, eat free pizza, and talk about where in their neighborhoods do people get resources? Where can we tell people about what we do? And we committed to go to 2 places a month and tell people what we did. And so we ended up that year going to 120 places, so a little more than 2 per month. But from 2009 to 2010, we grew by 13% just going to food pantries and soup kitchens and church events and just saying, hey, where do you get health care? Why are you afraid of the doctor? What are the barriers to care? Understanding that health care is 3% of somebody's 97% life, and health is the rest of their life. And the other things that get in the way of them coming to the doctor is important, are the reason they don't come. And we want them to be engaged in the exam room, so if we don't ever listen to what are those social determinants getting in their way, we'll never help them. And so in 2010, we said, well, that was neat. Now let's tell the people who come to us already the services we have. So we in-reached. And that's called outreach, is when you go out to meet new people. In-reach is when you talk to the people who already come and you say to them, well, you get dental here. Do you have an OBGYN doctor? Well, your kids come here for pediatric care. Where do they get their teeth cleaned? You seem to be, your PHQ-2 and PHQ-9 say that you have depression. Have you ever seen a counselor? We happen to have one. You know, those kind of conversations with people, taking the time to talk to them about that, as well as some outreach, really helped us. Again, from 2010 to 2011, we grew another 13% by using those kinds of methods. And then I said to you that in 2011, we opened our third site. That was a site that had been run by Kaleida, which is the biggest health system, hospital system in the area. They closed that primary care site because it was failing. It was losing money year over year, and they could not afford that loss any longer. So we opened that site, and we're open for 5 weeks in the end of 2011, and we grew by 23% just in 5 weeks, plus the additional people who we knew were needing care. Then the full year last year of having the health center open, we grew by another 49%, which brings us to 18,000 plus people. That's individual people that we care for in this community and provide services to. So we're almost at our goal. I guess technically we are at our goal because 99, but we're striking double plus one is really our goal. So who do we serve? I think I kind of told you this, but I think you probably know this if you do public health or think about it at all. So since 2008, we've had the delight of moving from second to third and back again of large cities in poverty. This is, bar none, the poorest city to be a child in the United States. So yes, the suburbs, great. You know, there's Clarence, wonderful. It will be the first, that is the highest ranking school district in the state. That's super. And actually City Honors is in the city of Buffalo, and it's one of the best schools in the entire state as well. But still the poorest city to be a kid. And if your mom is single, that means you probably have about an 85% chance to live in poverty. So that's today. What did I tell you about why we opened 26 years ago? Concerned citizens saw poor moms and kids didn't have a doctor. And that's still Buffalo today. So there's still a need, and there's probably always going to be a need. I wish we weren't the poorest place to be a kid. But if we can impact the lives of children by getting them access to primary care, we're the largest provider of books for Reach Out and Read, which was defunded by the federal government, but we still provide a book to every kid between their 6-month checkup and their year 5 to show moms and dads what reading to somebody looks like. Is that health care? Heck no, but it's health, right? Because if you don't show somebody how to read, that is the biggest determiner whether a kid will graduate. And what is high school graduation? Is the biggest determiner of who's going to get out of poverty. So literacy and high school education, and so we spend half of a 15-minute well visit talking to a mother about reading, safety in their neighborhood. Do you have guns in your house? Is it safe to take a walk? All those kinds of things, not just how quickly somebody at this age grows. Don't put the stroller at the end of the stairway. You know, all kinds of conversations with families to make sure these kids have a better chance than their parents did. Again, lowest school readiness rates in the state, and high school graduation rate of 54%. That's up from 46%, which I think we should be happy about and try to help to get some traction on. But overall in New York, including the boroughs of New York City, are at 1 in 4 kids don't make it. Only half the kids in Buffalo make it out of high school in 4 years. So, how do we serve people? Well, you know, clinically, we do things called, we develop registries. That means if you have a chronic disease, your name hits a registry. If you have diabetes, here's something I'd like to caution you for the rest of your life. People aren't diabetics. They are people with diabetes. Please, people aren't hypertensives. They are people with hypertension. So if you think about them as people first, and then maybe somebody who has something they suffer from or triumph over instead of a thing like the diabetic in room 6, and that's all they are, then they start to think of themselves as the diabetic in room 6. So I'd like you to own that. Your generation can go out there and realize they're people first. They're people who can't pay their rent, whose kid got kicked out of school, who don't have any heat, who can't read the application to work well enough to fill out a job application, and then they have hypertension. And they won't fill your medicine you prescribe for them because of all that other stuff. But they really wanted to in the exam room. It's just all that other stuff got in their way. But if we continue to think about them as hypertensives or diabetics and not people with all that baggage, which we all have, right? And we won't be able to impact those things with them. So we make a registry of people, and sometimes you'll hit a couple of registries because you might have heart disease and diabetes. You might have, you might be 2 years old and need your immunizations up to date, and you're off the growth curve. So we like to run reports and registries about chronic disease so we can look at people at a population level. So if we, as we care for each individual and we make their health a little better, we help to float the sea up higher, right? Then everybody's health improves. And you can't do that if you don't look at it in a registry kind of manner. If you don't look at it in a group as a population. And we look at preventative measures in that manner as well. We report to HRSA annually on our financial and clinical outcomes to assure that the model is effective so that we're using our money the right way and that health outcomes are improved. We focus on social determinants of health. So I think I already said that, but you know, who we serve and how we serve, I think those are the things that are important. We use a model of care where we have community health workers. And that is a thousands-of-year-old tradition of having lay people in a neighborhood or a community who know how to navigate. They're the person who knows where everything is. They also know which neighbors have a car and which neighbor is willing to help you. They're just the natural navigator of a neighborhood. And for many years, there's promadora, there is many other words for community health worker. Navigator is another one. But they are people who we've hired from our neighborhoods to help our patients deal with those other things. So yes, they make referrals. They help them to navigate getting the pharmacy products that we have at a lower rate and where those pharmacies are. And they help the providers, the physicians, nurse practitioners, dentists, social workers. So when somebody's in the exam room and their blood pressure is high and they haven't filled their blood pressure medicine for the past 3 months, and they confess finally that it's because they're really much more worried about the fact that they don't have heat, then the doctor has the opportunity to open the exam room and introduce to the community health worker who will sit down and do a HEAP application with the person and take them to HEAP and show them how to fill that out. So if your doctor's office isn't doing that for people who come in to seek care, why not? Is it because where you go, everybody can figure that out themselves? Is it because health is so much different than healthcare? Just something for us to think about. But our community health workers do a tremendous amount of that. It's a team approach. That is patient-centered care. The patient is the middle. The doctor's not the middle. My office isn't the middle. I'm not the middle. It's the patient, right? They're the most important contributing factor in this equation. So, and our community health workers are neighbors to people. So our patients come in and they feel comfortable because the people caring for them are the people from their neighborhood. So, and through our staff, the phone and live interpreters, we cared for patients in over 40 different languages last year. So, Buffalo is becoming, an increasingly important refugee landing spot for the United States. Third biggest. So there's 6 refugee settlement agencies just on the west side of Buffalo. And when you provide care, when you provide accessible care, and you provide care to people in the language that they feel served best in, and you do that without a big hassle, you actually become someplace where 40 different languages find their way to your door. In 2008, we cared for people in 11 languages. We thought that was a big deal then. So, but having a community-based board, having people who live in the neighborhoods, being nimble enough to to be able to see something coming on the horizon and say, this is important for the care of our community. That's what having a not-for-profit that is based in the community allows you to do. When you're part of a much larger system, that isn't your total focus. The ability to be able to flex and care for those things on the ground level is more difficult. So there's huge organizations caring for people who are still trying to figure out how many patients they care for in Buffalo, how many individual people, because it gets mixed in with their hospital statistics, how many different languages they serve in their clinics. They don't know. How to get around the phone. Is there any way we don't have to use the phone? Sure. Hire somebody who knows 40 languages. One of our offices has about 35% of the patients would like to be spoken to for their medical visits in Spanish, and so we do a lot of those interpreting live with employees. And then the other languages, again, we use the phone. Some dialects you can't get through the phone, so we use the live interpreters through the community. We also, like as I said, we hire from the communities. We hire from our neighborhoods. We pride ourselves in being a place where our patients can see an opportunity, where they can learn a skill. We know that that means that we'll have higher turnover, but many not-for-profits see that as part of their mission in a community. So we see that as part of who we are. It's important for people to be able to have those opportunities, and when they leave successfully to get a job where they're paid more or move on, then we're successful. That isn't a bad thing for us. So. Assessing the health of our patients and the community. This is kind of a messy slide, but it's fun, if you like health outcomes. So Neighborhood Health Center, that's us. That's my organization. We look at every year 18 different health outcomes, and we report those to the federal government, and they are transparent. They're on a federal website that you can access, and you can see where we line up against other federally qualified health centers as well as the nation. But some of the ones that I think that we feel most attached to are the percent of newborns that are below normal birth weight, or called low birth weight rate, which is an indicator of access to OBGYN care. It's also an indicator of the long-term health of the people who live in your community. So we have been able to stay below 7% for the entire time that we've served this community. And percent of newborns below normal weight nationally is 7.4, and that's including everyone, not just people of poverty. So one of the leading ways to prevent low birth weight is a first trimester, or in that first 12 weeks of pregnancy, having your first prenatal visit. I didn't change my slide. Nationally, it's actually 71%. I have an error in my slide, sorry about that. But at Neighborhood Health Center, it's 92%. And that's fallen a little. We were at 97%, but since we've grown so rapidly, it's gone down a little. But that's because we're providing access to a brand new community of people who have not seen, one, the importance of preventative care, and two, the ability to access OBGYN services. So those are things that we are learning about the community. But in Buffalo itself, it's it is in the 68 to 70%, nationally at 71%. And so we're quite proud of that fact that we have put in place care models. We do free pregnancy tests for the entire community, and if someone has a positive pregnancy test, we tell them about the services that are available to them. And if they'd like an appointment, we make sure that we reserve spots for people. Even if they come in at 11 and a half weeks, we will be able to get them in before the 12th week. So, and we follow up with people. We use a community health worker is assigned to every pregnant woman to make sure that she has some place to bring the baby home, that she has the resources that she needs, that she understands the importance of getting to those visits, that she understands the importance of getting her teeth cleaned at least once during pregnancy, because an inflamed mouth will lead to a higher likelihood of early delivery, as well as introducing pregnant women to the pediatricians in our office. So those are to get people in a preventative mode. People the refugee families that we meet, some have lived in in refugee camps in Thailand for 5, 7, 10 years. And the thought of coming in because you're healthy is astounding and outside of anything that has reason to people who've lived in the Congo. So why would I do such a thing? Or why would pregnancy is a state of health? If we could get more Americans to believe that, that would be super. But there's some place between never thinking you have to go to the doctor because you had your last baby in the Congo and thinking that everything's an illness, which a lot of Americans believe. So trying to help people to see that, geez, if we just visit with you and measure your tummy and we talk about what you're going to do, this is going to make your baby healthier. Now, imagine that in a language you didn't understand. If your healthcare provider decided not to use the telephone interpreter or an interpreter in the room. So imagine, take yourself to someplace beautiful. Take yourself to the best hotel in France, but everybody speaks French, and you have the worst abdominal pain of your life. And you're trying to ask for help in the most beautiful resort in France. I won't even put you in the Congo. And say to yourself, how frustrating and sad and upsetting can that be to try and get care when you can't speak the language and the people around you all speak another language and there's some way for them to get you the language you need, but they just won't or can't. So imagine that for the people that are in our own community. Hypertension, again, and diabetes. I think those are rates that even with our growth, we've been able to maintain those. And part of the reason we maintain those is because we measure them. So, in closing, we have a little bit of time because I'm sure you're excited about questions. So, the Institute for Healthcare Improvement, the Triple Aim. If you haven't thought much about the Triple Aim, if you haven't heard it yet, I encourage you to think about it every day. And the Triple Aim is, the Institute of Healthcare Improvement really says, how can we be a nation that focuses more on prevention? How can we put our money where our mouth is? They say that there's 3 things that'll do that. Is improve the patient experience by saying the most important things are quality and satisfaction. Improve health of populations by using population health, as we talked about, and using public health and using data to drive what we pick to work on together, and reduce the per capita costs. So I propose to you that federally qualified health centers are a vehicle to do all of these things. Primary care is experiencing our day in the sun. This is the first time in this nation's history that there's a conversation about prevention. This is a country about personal rights. Preventative steps to remain on this earth, to take preventative steps, to do all the things you want to do, to have personal ownership for them, is a new conversation here. Public health and primary care have an opportunity to unite and get the word out about the 97% of things that we treat that people can prevent themselves. This is new for us as a nation. And community health centers have used needs assessment data and population health efforts to improve the health of really the most vulnerable communities, but we're now becoming seen as a model of care for all people, because my belief is that underserved is in the eyes of the beholder. I'm underserved if I go someplace and I don't get all of those things. Maybe for me, it sounds intriguing to have a counselor on site who could talk to my children about problems with getting to school, or help with figuring out not just what a mammogram is, but how the heck do I get there? And do I need somebody to go with me? And what bus route is it on? And those kinds of things to help really make sure that you'll follow through with those preventative things. And I think right now that the public health community and community health centers we do have an opportunity to do more things together, to see all of those needs assessment opportunities that we've had, data collection and reporting information that we've provided to the federal government, and now the transparency that the movement is affording, so putting it up on websites for people to see. I think those are the place where we can intersect with formal public health. But I hope that when I leave you today, you will believe that this is one model of primary care that is doing public health right now. Everett Health Center. Here's some resources for you.